body, with a weight approximately 3 kilograms in men and 2.6 kilograms in women. The osseous component of the marrow is the cancellous bone, which is surrounded by the cortex. And the cancellous bone is formed by primary and bridging secondary trabeculae. And this trabeculae provides architectural support and also the mineral source. Cancellous bone is also the site of osteoblastic and osteocytic activities. It's all inside the marrow cavity. The vascular system of the marrow is complex with an arterial supply, mostly from the nutrient artery that penetrates into the center of the medullary canal. And when we're looking at of the long bones, we often see that long, bright area in the center of the bone, T2 weighted or proton density weighted PET suppressed images. And on the axial T2 weighted image up here, you can actually see these individual vessels penetrating through the cortex, and it's almost like a spochial pattern forming inside. And this is the nutrient artery that's penetrating inside the tibia, approximately indicated by these arrows. So when we're looking at MRIs on T1 weighted images, so what we see is red and yellow marrow. Red is the hematopoietically active portion of the marrow, and the yellow is, as the name indicates, is mostly fatty part of the bone marrow. And because these two different parts of the marrow differ in their chemical composition, we also see different signal intensities on MRI looking at different body parts. One thing that's interesting is in infants and young children, the red marrow is more cellular, and it has about 40% water, 40% fat, and 20% protein. As we get older, we start losing that, and if by the age 70, the red marrow is approximately 2/3 fat, almost 2/3 fat, third less water, and much less protein. You can see that the protein level actually goes half. And I wanted to put this example up here. It's a 6-month-old kid. You can see the signal intensity of the red marrow is pretty dark, like on this T1 weighted in the coronal image, in both proximal femurs and the pelvis. These patches of red marrow in someone who is 41, that's more something we're used to seeing in the joint imaging. They're much more subtle compared to this. And, you know, as we get close to 70, so our even red marrow will have more fat inside. When we look at the composition of yellow or fatty marrow, that's more stable. It has approximately 80% fat, 15% water, and very little protein. And it tends to be more stable when you look at signal, it's the same. So, in the fetus, when we look at the marrow early on, in the second trimester of pregnancy, the long bone shafts have very small medullary cavities and thick cortices, which 1 and T2 weighted images without to see teeth. Here's an example in this second trimester, I think 20-week of child on this MR. This is the skull and femur. We really can't see the marrow cavity. All we see is very thick cortices, and it's very dark, and so this is not the stage. As we get closer to term, the marrow spaces progressively expand, and the bones start to reflect the entirely hematopoietic pattern of marrow-typical. Here's an example. This is a third trimester, and you can see that there is now appreciable marrow cavity, and cortices are thinner at this point. During the neonatal period, the signal intensity of red marrow is hyperintense on T2, and iso or hypointense to that of skeletal muscle on T1 weighted images. That's due to higher percentage of cellular marrow with abundance of water and hemocysteine. This is a very important point to make, because in every other age group, we always look at T1 weighted images of the marrow to that of skeletal muscle to decide whether red marrow or a pathologic marrow infiltration. Following the neonatal period, if T1 weighted bone marrow signal is found to be lower than normal skeletal muscle, this should for a pathologic marrow infiltrating process. Here's an example of a newborn. You can see that the red marrow is essentially very similar to skeletal muscle, if not more hypointense. In the early months of life, the cartilaginous epiphyses have higher signal intensity than the metaphyses. The epiphyseal cartilage ossifies by means of endochondral ossification and initially contains dense trabeculae and red marrow that's hypointense to the surrounding cartilage. You can see the example here that we have the epiphysis. It's, at this point, it still has red marrow, though it's less or I guess more hyperintense compared to the metaphysis. And slowly we have the trabecular bone forming inside the epiphysis. After a short period, usually in about 6 months, the epiphyses convert to yellow marrow. And once the conversion is complete, the epiphyses and apophyses contain the greatest concentration of fatty marrow, and that's why it appears T1 images. Here's a hand MR early on in a 3-month-old, and you can still see the cartilaginous epiphyses, which hasn't been converted to yellow marrow. By the age of 1 year, the marrow in the feet and hands are entirely fatty without any foci of red marrow, unless there's an underlying disorder, whether that's some kind of an anemia or a neoplasm. Individual long bone marrow conversion also progressed from central to peripheral, and from diaphysis to distal metaphysis, and then to proximal metaphysis with variable symmetry. The rate is usually influenced by the location of the bone, age, sex, and the health of the individual, and there are some unknown factors as well. The final segments of the appendicular skeleton to convert are the proximal humeral and femoral metaphyses. And we see islands of red marrow in these areas in varying amounts during the adulthood, and those should not be mistaken for disease. Here's an example, as I mentioned. This is very bright T1-weighted signal in the epiphysis and the apophysis, and we see these patch areas of red marrow in this young adult, which is quite normal. When we look at the normal anatomical structures, the red marrow patterns sometimes could confuse the radiologist, especially if there is a history of malignancy and it's an elderly patient. But when we follow the rules, whether it's in the flat bones or the appendicular skeleton, we should have some red marrow in the areas where we would expect them. The metaphyseal equivalents of flat bones have similar marrow signal intensity changes to those of long bones. Such as here, we can appreciate the red marrow in the proximal femurs on both sides. You can also see the areas that are bright are the region of triradiate cartilage surrounded by some red marrow on both sides. So they are the epiphyseal equivalents surrounded by metaphyseal equivalents where you see the red marrow. So we see this in pallus around the triradiate cartilage, ischiopeutic synchondrosis, and sometimes adjacent to sacroiliac joints where we can see some red marrow. In skeletally immature patients, the patches of metaphyseal red marrow almost always have a flame-shaped configuration with their bases at the or adjacent to the physis. They have characteristic straight margins on the sides, and they show increased signal intensity relative to muscle on both T1 and T2 weighted images. Here's the example on this 13-year-old's knee. We have the flame-shaped areas on T1 weighted images with straight margins, again slightly bright on the T2 weighted fast-suppressed image. So this is quite normal. We should be thinking that this is stress reaction or a marrow necrotic process. It's quite normal for this age. Another issue that might come up is the fusion of the physes. When we look at the kids, early on we see the growth plates and later they disappear. The physeal fusion is a normal physiologic process of skeletal maturation, which starts with a mineralized bridge between the metatarsus and the epiphysis, ends with complete fusion. We wouldn't be able to tell in most patients where the growth plate was. Most frequently, the process of growth plate fusion starts centrally and proceeds away from the center towards the sides. During the process of skeletal maturation, the new cartilage is added to the epiphyseal border of the physis that's subsequently mineralized, forming a metaplastic bone. That forms the union between the epiphysis and the rest of the bone. But during this process of fusion, in some patients, there is a relative decrease in flexibility at these areas, especially in the young athletes. And this microtrauma during athletic activities might possibly cause some vascular damage and bleeding into these areas. And these might present as abnormal signals surrounding the growth plate that's in the process of fusion. And as you can see here on this T2 weighted fast-suppressed image, there's a lot of edema surrounding growth plate both proximally and distally. And there's very subtle changes on the T1 weighted images. I just wanted to put the same slide or the same slice on T1. You can barely see anything at that level. So this is called focal periphyseal edema or FOP zone, and it has been described as a normal variant. It's actually in these kids can be very symptomatic, although you can argue then why did they get the MRI, which distal femur trochlea of the elbow and occasionally the proximal femur may show some fragmentation of the epiphyses, but when we look at the MRI, we should be able to see normal fatty marrow in these areas that can help us differentiate from pathologic states. And another thing I wanted to bring up is this speckled appearance of the bones, especially in the hindfoot and midfoot after immobilization. Here's an example on T2-weighted fat suppressed image. These tiny foci of increased signal without very obvious changes on T1-weighted images, without showing any fracture. And people think that this is probably due to altered foot dynamics or immobilization, and it shouldn't be considered pathology. On MR, both cortical and trabecular bone produce little or no signal, essentially a signal void, that's outlined by signal in the adjacent tissues. Trabecular bone is present in greater quantities in the metaphyses and epiphyses, and it's more likely to be visualized in those areas. And you can see, especially on this 3T T1-weighted image, you can appreciate those longitudinal lines corresponding to trabeculae that are visualized. With use of higher magnet strength, I think we get to see more of the we used to. So one of the other things I want to mention is these pseudotumors in the proximal femurs. It's not unusual to see unique marrow signal appearances in metadiaphyseal junctions, especially in proximal femurs in the subtrochanteric region, creating these pseudotumor appearance. This is probably related to sudden change in the trabecular pattern, and it shouldn't be mistaken for a disease. Because what happens is, as you can see in that area, we have a lot of trabecular bone, and suddenly transitioning into the diaphysis, we have a change in the pattern. And when we see red marrow in that area outlined by normal fat, that could be for a lesion in that area. But as you can see, the signal is still on T1-weighted image brighter than skeletal muscle. That's what we would expect for the focus of red marrow. And in most cases, these are symmetric, although I've seen a few cases where you could see the symmetry between two sides. Those are more confusing. It is unusual to see purely yellow or fatty marrow outside the hands and feet at any age without any evidence of red marrow interspersed in that background. If you see that, then we always think about possibility of prior radiation in an area, and that's something we should mention in our reports. If you're looking at a pelvic MR and if you see zero red marrow, that's something to mention, or look up patient's history if possible. When we see the red marrow, patients, some people might be concerned about pathologic state. requiring unnecessary and uncertainty on the patient's side. This is in the proximal humerus, almost similar to the proximal femoral lesion I showed. Again, somewhat concave at top, showing pseudo-lesion appearance. So looking at the marrow patterns, it could be small areas of patches, it could be linear lines, or it could be small nodule or nodules, and could be a combination of or a combination of more than one of these patterns. Here's a patient with renal cell carcinoma, MRI was done, and my resident was wondering whether this could be a lesion. First of all, it's way too small to be anything worsened. Although metastatic disease, they must start from somewhere. But looking at the signal intensity, it's definitely much brighter than the skeletal muscle. There is a focus of red marrow in this patient. So one of the important and confusing things in the bone marrow imaging is focal nodular hyperplasia of red marrow. That's probably the most extreme pattern of red marrow hypertrophy we see. It is characterized by one or more larger nodules of red marrow, sometimes measuring up to several centimeters in diameter, in the background of normal fatty marrow, which is stimulating neoplasm. Here's an example. This is a patient. She was in her 50s, and she had a mucoid liposarcoma resected from this side, and she had radiation. She had this follow-up MR, and this MRI was read by a radiologist who said she has metastatic disease in the opposite side of the tumor. First of all, bone mets from soft tissue sarcomas are very rare. Another thing is this person really didn't pay attention to T1 weighted images in the same patient, same time. When you look at that area that's really looking worsened, there's barely anything on T1 weighted images. It's definitely much more hyper-intense compared to the skeletal muscle. So this was a focus of focal nodular hyperplasia. This is rare in normal individuals, but it's not uncommon in patients who are generating red marrow after aplastic conditions, or if they have received hematopoietic stimulating drugs. Especially in most cancer patients, they get red marrow stimulating drugs because of the worry that there's suppression of their marrow from chemotherapy. So we have to be careful to recognize this condition of these patients. That's why we have to look at the T1 weighted images and assess the bone marrow on this sequence as opposed to looking at the STIR and the T2 weighted images. Here's another patient with the same scenario. This is definitely asymmetric. When you look at the left intertrochanteric femur, it is pretty dense on T1 weighted image, though it's not more hypo-intense than skeletal muscle. And it's somewhat bright on the STIR image. And because this wasn't the most characteristic and the patient had no history of malignancy, ended up biopsying that lesion, which turned out to be hypercellular marrow without any evidence of disease. Nutrient vessels are visualized on MR images of long bones within the marrow space, as I mentioned earlier, as they enter through the cortex. In some instances, these vessels could be dilated, and in those cases, they could be called intraosseous varices. These could erroneously raise suspicion for a marrow-occupying neoplasm. But we have to review the sequential images and demonstrate the continuity with proximal and distal vessels. Here's an example where you see the penetrating vessel. This was called a lesion. Patient was about to see and manipulate. Diffuse dilatation of the intraosseous vessels are occasionally seen. Could be a mild form of vascular malformations. Interval proliferation of the vessels, when we have a prior one, in the follow-up, there is interval proliferation of the vasculature. Then we should think about some underlying pathology, which could be a septic joint or osteomyelitis nearby, which causing hyperemia, or a diffuse marrow infiltrating neoplasm such as multiple myeloma. Multiple myeloma has been shown to, and this is an example. You can see these dilated vessels, and it's out of the patient with known myeloma. So nutrient vessels, as we said earlier, should be going through the center of the bone, and since they're central and they might show increased T2 signal, not be mistaken for stress fractures, as these should not have any surrounding marrow edema. And sometimes red marrow can be seen in the periphery of long bones, especially on T1 weighted images on axial slices. They should not again be mistaken for fractures, as their signal intensity is much less impressive than stress reactions on T2 weighted or stirred images, and they tend to be more diffuse than stress reactions or fractures. Well, in conclusion, I'm hoping that all of you, when you're accepting bone marrow, be doing this on T1 weighted images as opposed to normals on or T2 weighted fast breast image. And red marrow, just keep in mind that its presence is variable in pretty much all the age groups, and you should get some red marrow even in elderly. They're not